Hey everyone, welcome to this explainer. Today we're grabbing our clinical maps and walking through the entire pathway of Henoch Schönlein Purpura or HSP. If you've ever had a kid walk into your clinic with that very specific, very alarming rash, you know exactly why we need to nail this diagnosis. We're going to break down the clinical picture, the complications, and the long-term management strategies, all pulled directly from the clinical source notes. Let's get right into it. Here's our agenda for today. We'll be looking at visualizing the diagnosis, the systemic clinical picture, investigations and management, admission criteria and complications, when to safely discharge, and finally, long-term follow-up protocols.
All right, Section 1, Visualizing the HSP Diagnosis. Take a good look at these real-life clinical images. We're seeing a distinct, raised purpuric rash. And notice the pattern? It's heavily concentrated, strictly located on the extensor surfaces of the lower legs and moving right up onto the buttocks. It's not just a random scatter, it's a highly targeted presentation. If you see this in a typical 2 to 8-year-old patient, your clinical suspicion for HSP should immediately go through the roof.
But here's the catch. While that purpuric rash is super obvious on the skin, beneath the surface, immunoglobulin A is targeting a whole lot more. The IgA doesn't just hang out in the skin, it triggers arthralgia in the joints, IgA nephritis in the kidneys, and a generalized vasculitis. This is a deeply systemic issue, not just a dermatological one.
So formally speaking, HSP is an IgA-mediated vasculitis of unknown etiology. It affects small vessels all over the body because of that IgA deposition, and honestly, it's that specific deposition that drives the massive array of symptoms we're about to look at.
Moving on to Section 2, the systemic clinical picture.
Okay, this breaks down the classic triad you absolutely have to look out for: joint pain, severe abdominal issues, and renal involvement, plus some potential neurological symptoms. For the abdomen, we're talking non-specific pain that usually clears up in about 3 days, maybe with some nausea, vomiting, hematemesis, or melena. For the joints, watch for arthralgia and limping, especially in large joints like the ankles and knees. The good news? That usually resolves spontaneously in a day or two. Renal-wise, look for microscopic hematuria, proteinuria, hypertension, and edema, specifically swelling in the hands, feet, sacrum, or scrotum. And finally, keep an eye out for neurological signs like headaches, seizures, or paresis.
Now pause for a second because we need to talk red flags. If your patient has severe, non-resolving abdominal pain, you have got to quickly exclude acute surgical emergencies. We're talking intussusception, testicular torsion, pancreatitis, peritonitis, and perforation. You just can't assume the pain is from standard HSP inflammation. Rule out the life-threatening stuff first, always.
Section 3, Investigations and Management.
For every single patient, no matter how mild they look on day 1, you have to run this mandatory panel. First up, blood pressure and an early morning urine dipstick to catch sneaky renal issues like protein or hematuria. You're also ordering a full blood count and blood film, urea and electrolytes, and albumin. Finish it off with a throat swab, blood culture, anti-streptolysin O, and a full coag profile to get your complete baseline.
When it comes to first-line management, there's a really clear split. We generally reach for NSAIDs, specifically ibuprofen, for joint pain. But listen carefully. Use NSAIDs with extreme caution if there's any hint of renal involvement. On the flip side, if you're dealing with severe abdominal pain, we pivot completely. You'll want a 2-week course of prednisolone at 1 mg per kilogram per day to aggressively knock out that inflammation.
Section 4, Admission Criteria and Complications.
These admission criteria, they are completely non-negotiable. You're admitting that patient immediately if they have orchitis, moderate to severe abdominal pain, or arthritis in more than 2 joints. Plus, if you detect proteinuria, any GI bleeding, or if the kid simply can't ambulate, they need immediate inpatient care. No exceptions.
And you know, even if they don't meet those criteria and you send them home, your job isn't quite done. You must explicitly warn the parents to seek immediate medical advice if a sudden headache, rectal bleeding, or severe abdominal pain develops later.
All right, Section 5, When to safely discharge.
So you admitted them. When can they go home? Well, only when they meet these strict steps. Number 1, diarrhea has stopped and the pain is completely resolved. 2, hemoglobin is stable and electrolytes are back to absolute baseline normal. 3, the patient is drinking fluids freely and has normal urine output. Oh, and a quick note from the source material. They might be sent home on a daily 2.5 to 5 mg dose of folic acid upon discharge.
And finally, Section 6, Long-term follow-up protocols.
For the general practice follow-up, both uncomplicated and complicated cases require a really strict 6-month protocol. For uncomplicated cases, we're talking a weekly urine dipstick at home until clear, plus monthly blood pressure checks for 6 months. If everything is totally normal after 6 months, you can stop. Complicated cases, like if the urine showed greater than +1 blood or protein but renal function was normal, do that exact same weekly urine and monthly BP check, but you're layering on a routine follow-up in a pediatric clinic.
Now, when do you escalate? You absolutely must refer to a nephrologist if, after 6 months, you're still seeing +1 protein, macroscopic hematuria, heavy proteinuria, or persisting hypertension. Immediate nephrology referral is also triggered if the protein to creatinine ratio is over 100, if there's +3 protein for 3 straight days, or any impaired renal function. And if that rash starts acting strange or spreads rapidly, that's an immediate rheumatology referral.
Check out the sheer scale of this long-term timeline. It's pretty wild. Weeks 1 through 4, weekly checks for renal function and BP until normal. Year 1, a yearly check of BP and an early morning urine dipstick. Year 5, a nephrologist needs to check the glomerular filtration rate. Believe it or not, this monitoring can extend up to an astonishing 15 years. You only give a final discharge if renal function tests are perfectly normal with 0 proteinuria.
Which brings us to our final point. As we wrap up this explainer, we have to ask, why must we advise recovered HSP patients to avoid smoking and obesity and closely monitor them during future pregnancies? Well, given that mind-blowing 15-year pathway, that rare risk of late-stage renal failure demands extreme vigilance deep into adulthood. It really shows how a recognizable childhood rash can quietly echo for decades. Thanks for joining me today, and definitely keep these protocols handy for your next clinical encounter.